Thank you very much, Prof. James. That was excellent. Thank you. So next we have time for live question and answer. If anyone have any question, type them in the question and answer box. So we will go and start with the first question. Dr. Ahmed was asking, what is the most sensitive diagnostic test for myasthenia gravis?
In my experience, single fiber EMG is the most sensitive. In our hands, we approach about 98 sensitivity. We study um, at least 3 muscles, the extensor digitorum in the forearm, the frontalis and the orbicularis oculi. If the deltoid muscle is weak, I'll examine that as well. And in our experience, we have 98% sensitivity.
Yes, yes, excellent. Thank you. The second question is they are asking, what does mimic myasthenia gravis? What does mimic myasthenia gravis? Mimicker.
There can be many things which can mimic myasthenia gravis, like polymyositis, myopathies, motor neuron disease, Lambert-Eaton myasthenic sometimes. So clinically, these things plus botulinum toxin, sometimes GBS, cranial variant that can mimic myasthenia gravis. And electrophysiologically, also these tests like sometimes polymyositis, myopathies, motor neuron disease, the RNS can be positive in that. So these are things can mimic clinically as well as neurophysiologically.
Yes, thank you. Another question is stating if can vitamin D help myasthenia gravis patient? Is in
I'm not aware of any information that would suggest vitamin D is directly beneficial to myasthenia gravis. I think vitamin D is a very necessary cofactor, particularly those on corticosteroids, as it will promote the absorption of calcium into bone. So for bone health issues, we use it, but I'm not aware. Maybe Dr. Malik has experience, but I don't.
Yeah, there are no such studies have been conducted on vitamin D, so we cannot claim that it helps. Indirectly, maybe there might be some role because calcium definitely is needed for the transmission across the synapse, the muscular junction. So maybe little role, but it's not proven by the studies.
Going back to the mimickers, I mean, other metabolic diseases, I don't know whether you mentioned thyroid disease could likely mimic myasthenia gravis in many cases.
I agree. Yeah.
And the one mimic that I've seen several times coming from typically internist and all are those who have myotonic dystrophy. And I've had my cardiothoracic surgeons call me at the last moment because they have a patient they want to do a thymectomy on, and the patient has obvious myotonic dystrophy and does not have myasthenia at all, but we're fooled because of the ptosis.
Thank you. What are the long-term side effects of having immunosuppressive agent? Was the next question. So, any suggestion?
Well, I think it really depends on the agent that we're using. And I showed briefly that one slide. So for corticosteroids, I'm always worrying about bone health, glucose health, and what it does physically and mentally. But the imurans, the azathioprins, the cutaneous skin cancers, which we see people commonly here because they've been working in fields growing tobacco, and the sun exposure with the azathioprine leads them to develop cutaneous basal cell and small cell carcinomas of the skin. For for many of these, the cyclophilins and mycophenolate, we don't have good handles. The teratogenicity is listed, um, and that's been our experience.
Thank you. Thank you, Prof. There is another question. There is any significant changes among males and females? I think they are mentioning regarding the myasthenia gravis. But it's not clear what they meant by, but there is any significant changes?
Significant changes regarding
Yeah.
diagnosis or the treatment, or
It's not mentioned, but I think the treatment may be effectiveness. Okay, the next question, it's what are the cost effectiveness of novel treatment compared with the traditional alternative?
Well, clearly eculizumab is expensive, and in the United States it's prohibitive, and I'm sure the same as elsewhere. We don't know what the costs will be of drugs like zilucoplan and efgartigimod and rozanolizumab, etc. But I would just add a caution as we think about these expensive drugs. And yes, they're probably going to be more expensive than corticosteroids and perhaps azathioprine and all. But in the patient who is not doing well, or the patient who develops diabetes and hypertension or osteoporosis with bone fractures, we need to start looking at the total healthcare cost of these individuals. Yes, we have a cost to treat MG, but what is also the cost to treat the side effects of my current therapy for MG? In addition, and we're just starting to see some of this data, is what is the cost to society because I can't go to work, or I'm taking 2 weeks out of every 3 months to get plasma exchange to treat my disease. And so I have lost work time. And what's that impact in terms of cost? And when we start to factor in these total costs, I think we'll come to realize that while the cost of some of these newer therapies are above our others, the total societal costs actually may be less. It's still an unknown, but I think we're going to find with time that we're going to approach that these may be beneficial overall because of these reasons, but only time will tell.
Thank you. Next question is by Amel, and she's asking, does myasthenia gravis get worse with age?
I'll let Yasser start with that one.
So I think it should improve by the age. All the immunological diseases, the immune system that goes down by the age, and I think it should improve by the age rather than going worse.
I believe the first 1 year could determine how progressive the disease is. It's usually if it doesn't worsen within 1 year, the study showed that they will be stable, most of the myasthenia. If they are not deteriorating within 1 year, they stay stable. I don't know whether Professor agrees with this.
In general, we use a 2-year timeline. And I would say in general, you're correct that if the first 2 years often determines their stability. We have been fooled on occasion, but I would agree with your comments.
Yes, thank you. They are asking, can I use plasmapheresis to remove the overactive antibodies from myasthenia gravis patient?
Yes, and that's the basis of why we do it. But I find with many patients, unless one changes their other concurrent therapy, they will often have a relapse of their disease. The disease comes back. I use plasma exchange in a small population who have failed everything, and I've not been able to use complement inhibition on them. And they're being exchanged on a regular basis. And it varies what that interval is. And so I'll use one plasma volume. Sometimes I can get away with every 2 weeks, sometimes every 4 weeks, rarely 6 weeks. So it's not, they don't get long duration improvement from it, but it's a way to rapidly clear antibody and give them a temporary reprieve, if you will.
I fully agree, but I mean, with the institution of or introduction of eculizumab, that would make the life much easier. Because with plasmapheresis, you need to admit the patient in ICU, keep them 2 weeks, and it doesn't last for longer time as well. I guess we have 2 more minutes, Dr. Salama.
Okay, there is another question. One is asking, my colleagues identify an extremely rare case with the C1 inhibitor deficiency acquired angioedema, non-Hodgkin lymphoma, and patient with myasthenia gravis. What would be the best treatment?
Well, I'll start, and Professor Malik and Madame can answer as well. Fascinating case. Ideally, you'd want a C1q inhibitor to treat part of the disease. That is under development at this time, actually, but it's not been tried in myasthenias. I think the therapies may well have to be different, clearly with immune suppression. And so from an MG perspective, I would start with what you feel treats best. Whether the complement inhibition to C5 will help the angioedema or not, methodologically, I'm not convinced it would, but they may respond. I don't have any experience, so I don't know how best to treat that. Complement, etc. Many of our drugs aren't going to touch the Hodgkin's lymphoma, so it's probably going to be multifactorial therapy designed to treat each subcomponent that they have. But I welcome answers from the others in the panel.
I fully agree with you. I mean, the other component would be rituximab option.
And rituximab is, by the way, by the hematology people, it's being used in one of the regimes that is used for the non-Hodgkin lymphoma. So rituximab, I think it is the one of the drug that can be beneficial here.